السلام الملكي.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين، الرحمن الرحيم، مالك يوم الدين، إياك نعبد وإياك نستعين، اهدنا الصراط المستقيم، صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
السلام عليكم جميعا، سعد الله صباحكم. Okay. Good morning, everyone. Welcome to our meeting, Promise. This meeting is a collaboration between the Ministry of Health and the Saudi Society of Clinical Pharmacy on PNH and aHUS landscape. Both are rare but significant condition that affects patient blood and overall health. This meeting aimed to provide a comprehensive overview of PNH and aHUS, pathophysiology, diagnostic challenges, treatment options, and the implication for patient management. As we delve into these intricacies of these rare diseases, we will highlight the current advancement in research and clinical practice that aim to improve outcome of patients living with these diseases. Understanding the complexity is crucial for healthcare providers, researchers, policymakers alike, as it allows us to develop a better strategies for diagnosis, treatment, and support for affected individuals. Given the rarity of these conditions, awareness, education, and collaboration among healthcare professionals are essential to advance our understanding and improve patient care. We have a fantastic agenda lined up that includes leading experts in the field who will share their insights on critical topic. I encourage all of you to actively participate, ask questions, and share your insights as we move through this program. Together, we can foster a vibrant dialogue that will ultimately enhance our understanding and optimization of patients' care. Lastly, we would like to thank our partners for sponsoring this event, Subi, AstraZeneca, and Amgen. Now with our first speaker, Prof. Ahmed Aljedai, he will be talking about economic and global epidemiological burden of aHUS and PNH. Prof. Aljedai is the founding president of Saudi Society of Clinical Pharmacy, and he is the Assistant Deputy Minister for Therapeutic Supportive Services at the Ministry of Health. Prof. Aljedai, تفضل.
طيب، السلام عليكم ورحمة الله وبركاته. أسعد الله صباحكم جميعا. بسم الله الرحمن الرحيم. Can I get the clicker, please? Thank you. Thank you. Okay, so I promise this is not going to be long. So I'm not a specialist in PNH or atypical aHUS. That's a declaration and a disclosure. But I know about the burden of illnesses, especially when we talk about the overall healthcare utilization of healthcare resources. So I don't have anything to disclose regarding this presentation, and I will not be discussing any off-label use of medications. So this is what I'm going to cover. Really quick introduction. Some epidemiology. I know we have more details coming up in this program, so I'm not going to dwell into it much. Clinical burden. Also, we do have another speaker who's going to talk to us about the clinical burden in more details. But I think it's very important for us to understand, in order to look at the overall burden of the illness, to look at it from multiple aspects. Number one, of course, is the clinical burden, followed by the humanistic burden, quality of life, and economic burden. Then, in one slide, I'm going to tell you what's coming up in the future. So, again, I'm not going to define atypical aHUS or PNH for you, or talk about the pathophysiology, because I know you are all familiar with this. The most important thing is what we see in terms of clinical manifestations in patients upon diagnosis or prior to diagnosis, including anemia, thrombocytopenia, and acute kidney injury that could lead to chronic kidney disease and end-stage renal disease for atypical aHUS. With PNH, anemia is the main clinical manifestation with intravascular and extravascular hemolysis, unfortunately, and also thrombosis. So you get actually both sides of the equation. And this is followed by usually smooth muscle dystonia and ultimately chronic kidney disease. So looking at the global burden of rare diseases, it's very important. Both atypical aHUS and PNH are considered rare diseases. Now, the prevalence and incidence globally varies between region to region, between country to country, and between different races. And I have to be honest with you, it's not easy to find accurate numbers, even in well-developed countries such as the United States, because of the rarity of the disease, and I'm going to talk to you about this in a few minutes. But it's very important to understand that assessing the global burden of the disease will actually help in sharing the knowledge and accelerates research advancements. You know, 15, 20 years ago, we really didn't have much to offer those patients. Nowadays, we have actually multiple therapeutic modalities where we could introduce, and from medications to other health technologies, including stem cell transplants in certain situations. Now, it's very important also to focus on the fact that these diseases have huge impact on quality of life. And I'm going to share with you some of the impact in a few minutes. We at the Ministry of Health, we believe in patient-centered or person-centered care and value-based care. And we would like to address these rare diseases and not to forget about them when we move forward in our healthcare transformation program, and just focus on the chronic diseases or the well-known diseases that lead to increased mortality in this region, such as cardiovascular diseases and other non-communicable diseases. So it's very important to address the need of those patients who are diagnosed with some form of a rare disease, and not only PNH or atypical aHUS, it's actually many other rare diseases. And this is maybe a good maybe time to plug in the rare disease conference that is happening actually this tomorrow and the day after tomorrow, organized by the Saudi Society of Pediatric Neurology. We also have an annual rare disease event done in collaboration with the Saudi Society of Clinical Pharmacy and Ministry of Health, which will be announced inshallah soon. Now, one of the issues with these diseases is the high economic burden. Unfortunately, these diseases carry not only high costs in terms of diagnosis and management and referrals, but also high healthcare resource utilization. And I'm going to show you in a few minutes when we talk about the budget impact, how the healthcare resource utilization is increased significantly once the patient is diagnosed with these diseases. Now, on the other hand, we have also the cost of lack of treatment. So if we do not treat them, okay, there is also a cost which includes but not limited to, hospitalization, ER visits, admissions, ICUs, renal replacement therapy, and blood transfusion, you name it. So it's very important for us when we move with our model of care in Ministry of Health, we move in a mindset that addresses these rare diseases by putting certain policy framework and policy development that will help not only identify, appropriately refer to a specialist, but also manage these diseases appropriately, and again, in a person-centered, value-based care model. Now, quick epidemiology. As you can see, there is wide variation of the prevalence and incidence. So ranging between 0.23 to almost 2 in France for atypical aHUS. Now, people could argue, the incidence of the Mediterranean and the prevalence of immigrants in France, but also we can see wide variation within similar countries, like Scandinavian countries. The overall incidence is between 0.26 to 0.75 per million population for atypical aHUS. Usually it happens in age of 20 years, this is in 20 years and younger, and for all ages is between 0.23 to 2, as you can see. Now the prevalence is around 2.2 to 10 per million population in patients less than 20 years, and around 5 per million population across all ages. Now, in children, atypical aHUS affects females and males equally, while in adults it occurs more frequently in females. When we switch gears to PNH, you can see also rarity or scarcity of data when it comes to the availability of published data regarding the PNH prevalence. So the global prevalence of PNH is estimated to be as high as 16 individuals per million people, and the annual global incidence of PNH is estimated to be around 5 to 6 per million people. Most patients who are affected by this are adults between the age of 30 to 40 years, but children also can be affected, and it occurs between men and men equally, so there is no gender differences. Now this is very important. The issue of rarity of the disease itself makes it difficult to come up with accurate prevalence and incidence data globally. But not only this, there are other factors. Diagnostic challenges. It's not easy to diagnose these medications, especially for non-specialists, and in hospitals that are not equipped with the right diagnostic modalities. Also, the limited access to specialized care, not only in Saudi Arabia, but all over the world. If you go to the United States, most people live in rural areas. They don't have access to specialized care centers. So referral takes some time before any primary physician would suspect something like atypical aHUS or PNH. Geographic disparity, again, we talked about this in the prevalence slides. Resource limitation in terms of diagnostic tools and availability of labs that are equipped with personnel who are qualified, trained to diagnose such diseases. And finally, I think the lack of established registries in many countries. Now, fortunately, we have a registry here in Saudi Arabia under Ministry of Health for all patients who are being diagnosed and treated for PNH and atypical aHUS. Now, what about the clinical burden? This is a very important slide. Look at this. So we're talking about inpatient utilization, so hospitalization. More than 60% of the cases they require. Around 24% inpatient admission. The issue with this is not only hospitalization, but the length of stay, the hospital length of stay. They stay long. Average, a median length of stay of 16 days. Around 15% same-day hospital readmission. So you discharge the patient, they are readmitted within the same day. 15%. 42% of patients receive blood transfusions. Around 30% of patients receive therapeutic plasmapheresis during inpatient stay. This is for atypical aHUS, and around 17% of patients receive serum transfusion during the inpatient stay. The outpatient utilization, 76% of outpatient hospital visits, and the most common treatment in outpatient is eculizumab. Comorbidities, almost 60% renal diseases, 11% CHF, 10% chronic pulmonary diseases, 8% diabetes without chronic complications, and other cardiovascular diseases, rheumatic diseases. This is a retrospective claims data coming from insurance companies. It found high rates of hospitalization, up to 40%, and emergency department visits up to 50% among PNH patients. So it's not better than atypical aHUS. We have also an issue with those patients in terms of hospital or healthcare resource utilization. Now, it's very important, such as similar to many other rare diseases, it's very important to put a lot of emphasis on early diagnosis. Because you could, by intervening early, you could actually prevent lots of the complications down the road. So we do have challenges in early diagnosis, as we mentioned before, but also we have hospitalization rates, overall utilization, as well as long-term management requirements. This is a lifelong term management for those patients. Also burden on healthcare providers, as well as the need for specialized care. What about the economic burden? Now, the data on direct costs associated with atypical aHUS is limited. However, there was a study that showed reduced healthcare burden on treatment with C5 inhibitors. So basically, if you treat with a C5 inhibitor, you actually overall, on a long term, you reduce the overall healthcare expenditure. Now, we know these medications are expensive, okay? But at least we know that from 0 to 3 months pre-index, which means the treatment, there was a reduction, as you can see, from 2000 to 1800. In terms of 0 to 3 months post-index, there is a reduction, significant reduction of about $1,500 US per patient per visit, and 3 to 6 months post-index as well, a significant reduction on the overall. Now, we do have an issue, excuse me, an issue with this, because the way our health system funding is structured based on what we call multiple chapters within the budgeting. So for example, we do have a chapter only dedicated to the payment for personnel salaries. We have a chapter for medical supplies and medications. We have a chapter for equipment and CapEx. So it's not easy to transfer or extrapolate between these international numbers to our existing health care system payment model automatically. But it's very important also to look at the use of thank you, the use of C5 inhibitor. شكرا لك. The use of C5 inhibitors. This is one of the studies, and you'll find multiple studies looking at ravulizumab versus eculizumab, and eculizumab versus standard of care and others. Now, this study, for example, showed that average annualized cost of ravulizumab over a lifetime for an adult was around 210,000 US dollars. That's a lot of money, okay, almost million riyal. But it was actually a 32.5% reduction versus eculizumab. Now, again, this is a little bit old data. This compares it with eculizumab branded version. Now we do have eculizumab biosimilar. So besides, this is also different pricing than what we have here in Saudi Arabia. So again, we need to take this with a grain of salt. Let's not extrapolate automatically from international studies or international figures. That's why we do our own budget impact analysis. Excuse me. That's what we did. So we developed a model where we evaluated all direct and indirect medical costs, looking at the total population, the population with atypical aHUS, the targeted population excluding DGKE mutations, market share, and clinical outcomes, resource utilization based on disease management. And we looked at the total budget cost when we wanted to introduce ravulizumab to Ministry of Health. Ministry of Health. Sorry, I am sorry. Okay. Can you see it now? هذه يمكن ما هي clear. So anyway, خليني أجلس أجي هناك أحسن. Okay, sorry والله. طيب. So basically, as you can see, we looked at all the medical and all the direct and indirect medical costs in order to see whether the introduction of ravulizumab on top of what we currently have or we used to have, eculizumab, would add or inflate the budget for management of those patients or not, or would save, okay? And again, remember when we talked about the previous studies, we said prices are different, payment model is different, the cost of health expenditure is totally different than us. So we really had to do it ourselves. And then we compare two scenarios. Scenario number one, scenario with ravulizumab, and the second scenario without ravulizumab. So if we add or we do not. And now we get the difference, and the difference is actually the net budget impact, whether increase budget, inflation, or decrease or savings. Now, I'm not going to get into these details in terms of numbers, but as you can see, we looked at multiple things. The drug cost, administration costs. We even look at the administration costs. We calculate the syringe, the swab, the needle, the nurse time and nurse salaries, the physician visits, everything. We look at also, we calculate the cost of adverse events. And as you can see, we compare it across multiple years. We have a time horizon of 5 years. So we look at the budget impact over 5 years. Is it going to increase or decrease? Or sometimes it's actually a neutral budget impact. We also look at the complications. How much introduction of ravulizumab would decrease the complications compared to eculizumab? Okay, or maybe cause complications, other complications. So we calculate also the cost of managing these complications. We also calculate the cost of monitoring costs. And we put everything into our model, where we identified this as the average cost per patient over 5 years varied according to the adopted treatment with eculizumab and with eculizumab. So as you can see, I'm going to go the final here. Sorry. Here, as you can see, for ravulizumab, the overall in terms of patients 1 to 17 years, يعني if we again هذول كلهم pediatric population based on the international definition, the overall budget impact per patient over 5 years is 1.8 million for ravulizumab versus 2.2 million for eculizumab. Again, that was before the eculizumab biosimilar, because eculizumab biosimilar was just registered. So again, replugging the numbers with eculizumab biosimilar would maybe change the equation. Age group 18 years and above, the total cost is 3.6 versus 5.3 million for eculizumab. So as you can see, there is clear savings here. So with PNH, this is another study, international study, that looked at the productivity costs without caregiver associated with the treatment of eculizumab every 2 weeks, or ravulizumab once every 8 weeks. We also developed a model for us for PNH. Very similar structure or skeleton of the model. The total spendings, this is a summary, the net budget impact in patients with ravulizumab. The total spending over the period of 5 years will increase by 16% without the managed entry agreement. I'm not going to get into the details of managed entry agreements now. And 21% increase with the managed entry agreements on introduction of ravulizumab in the overall population when compared with award without ravulizumab, which is expected because you're introducing actually an expensive medication. This is the net budget impact in patient treated with pixitacoplan, which is another agent for management of PNH. And as you can see, also the total spending over the period of 5 years will increase by around 31 million without the managed entry agreement. But with the managed entry agreement, we were successful to bring this down to 24 million. Remember, this is over 5 years plan, or 5 years time horizon. Now, enough talking about money. Let's talk about humanistic burden. And this is very important. This is a real-world findings that confirm the detrimental effects of atypical aHUS on patients' daily life while being treatment with C5. So before and after, as you can see here with the eculizumab and ravulizumab, one of the major important advantages of ravulizumab is the frequency of administration. So as you can see, actually ravulizumab scored much higher than eculizumab. Also in terms of changing my career goals, the frequency of infusion impacted my ability to get things done, and all of these things. So absolutely there is an improvement with the treatment, okay, versus no treatment. And there is a slight improvement with ravulizumab over eculizumab. I'm fine, thank you. Physical and mental impairment caused by PNH. This is for PNH. This is another study that looked at the patients reporting to work or activity impairment. As you can see, this is the total study participants in the green. The red one is study participants on ravulizumab. And the, I don't know how you look at it, this is brownish or yellowish color. Those are patients on eculizumab. So as you can see, there is also improvement in terms of patients reporting to work when you switch them from eculizumab. And most, again, one more very important aspect is bringing the patient to the hospital or to the infusion center to give it to them, compared to every 2 weeks versus 8 weeks, or depending on the dosing schedule. Also, we have the same study emphasized that the current treatment options for PNH do not completely ameliorate the disease impact on patient quality of life. And we know this, of course. So there is huge room for improvement to further improve the quality of life of patients on this. This is the data on QALYs for PNH and atypical HUS. C5 inhibitors have definitely changed the quality of life metrics in those patients when we first introduced them around 15, 20 years ago at least. And this includes reaching end-stage renal disease and requiring kidney transplantation, dialysis, and also other complications. Now, I want to finish with this. The area of managing rare diseases is very versatile, and there is always, every day there is a news about a study that has completed, either failed or succeeded in one of the rare diseases. So the medical advancements in this is expected to grow and advance for obvious reasons. Unmet need is one, because as you all know, we have around 7,000 different rare diseases, and less than 2% of them maybe have some form of management. So there is huge room for improvement in meeting the needs of those patients. So this is number one. Number two, and I'll be honest with you, it's lucrative money for pharma industry. They actually need to penetrate areas where there was no treatment in order to come up with the first treatment that could change the future of managing such a disease. So we do have unmet needs in patients. One of the unmet needs is the overall symptoms, such as debilitating fatigue, which is often associated with decreased activities of daily living. But also, we have issues with the management of C5 or introducing C5 inhibitors, because C5 inhibitors do not address all the factors that can lead to ongoing hemolysis in atypical HUS and in PNH, mainly anemia in both, transfusions in both, and severe fatigue in both. C5 inhibitors such as eculizumab or ravulizumab, they reduce the intravascular but not the C3 mediated or dependent extravascular hemolysis, which is something also a room for improvement, hopefully in the future. We'll get something that will address both. And the risk of breakthrough hemolysis due to insufficient complement inhibition is also a risk there. Both eculizumab and ravulizumab, they carry a box warning for meningitis, so that's why they have all patients, they need to be vaccinated with meningococcal vaccines before committing the patient to treatment. Also, we really need to focus on data that supports improvement in quality of life in a standard way, utilizing our health statuses in Saudi Arabia in order to see the impact on our patient population. And it's very important to address the information gap in public, and this is your role, all of you, in public and also for patients, because there is huge information gap with those patients. These are the several ongoing studies with different medications, as you can see here, from different companies. Some of them are in phase 3. Hopefully we'll see something coming out soon, and some of them are still in early phase 2. So, and most of them are addressing both atypical HUS and PNH, but they usually start with one and then follow with the other indication. So with this, I leave you with these slides to contemplate about the huge influx of new medications that we are going to get in the near future. Thank you very much, and good luck to all.